Hey everyone, and welcome to the Deep Dive. We all experience those everyday emotional ups and downs, right?
Definitely.
But what happens when those ups become like a whirlwind of boundless energy, or those downs plunge into a really profound, debilitating sadness? Today, we're peeling back the layers on exactly that, the complex world of depression and mania. We're drawing from a fantastic chapter in your Psychopathology and Mental Distress textbook, and our goal is, well, to really make sense of these challenging experiences. Our mission is to cut through some of the academic jargon and explore how these intense mood problems are understood, diagnosed, and treated across different perspectives.
Exactly.
We're going to unpack the science, the psychology, and even the societal factors at play. And to help us navigate this, we'll meet two hypothetical individuals, Shirley and Don. Their stories will really bring these concepts to life as we go.
Indeed. We want to offer you a clear, accurate, and engaging overview that respects the academic rigor of your material while making it easily digestible for anyone studying mental health. We'll start by defining these intense mood states, then guide you step by step through the major theories, diagnostic criteria, cultural considerations, and of course, the various treatment approaches.
All right, let's dive in and get started. So, to set the stage, how do we fundamentally distinguish between depression and mania? What are the core experiences here?
Well, what's truly fascinating is how distinct yet sometimes interconnected these two states can be. Depression, as your chapter highlights, it isn't just feeling sad. It involves an intense, often debilitating sadness and melancholy, a pervasive, pessimistic worldview,
Right?
and a profound loss of interest or pleasure in activities that were once enjoyable. Anhedonia, basically.
Okay.
Mania, on the other hand, is almost the mirror image, characterized by an unusually elevated or irritable mood, boundless energy, and sometimes a significantly distorted sense of one's own capabilities or importance.
That distinction is so important. Let's bring in Shirley here. She's a 34-year-old accountant, and she's been struggling with extreme depression for about 6 weeks now.
Okay.
She feels utterly despondent, has lost her appetite, sleeps maybe 14 hours a night, but still feels exhausted all the time.
Wow, yeah.
Struggles to concentrate at work, feels completely worthless. She's even had thoughts of suicide, but paradoxically, lacks the energy to act on them. Her experience truly paints a picture of that profound, debilitating sadness, doesn't it?
Absolutely. Shirley's symptoms align perfectly with the core features of depression. Now, consider Don. He's a 25-year-old freelance writer. For the past 2 weeks, he's been incredibly energetic, completely convinced he's on the verge of writing the greatest novel of the last decade.
Okay, so grandiosity there.
Exactly. He's barely sleeping, maybe 2 hours a night, and has been on an impulsive shopping spree, which actually culminated in a drunk driving arrest.
Oh, wow.
His grandiosity, the relentless energy, and those really risky impulsive behaviors are classic indicators of mania.
It's incredible how different those two experiences are. So how do clinicians actually take these real-world experiences, like Shirley's and Don's, and categorize them using the formal diagnostic systems, like the DSM and ICD?
That's where the concept of mood episodes comes in, and they're crucial building blocks for diagnosis. A depressive episode is defined as experiencing either intense sadness or a depressed mood or a significant loss of interest in activities for 2 weeks or more.
2 weeks minimum.
Right. And crucially, this must be accompanied by at least 3 additional symptoms. Things like significant changes in appetite or sleep patterns, pervasive fatigue, feelings of worthlessness, trouble concentrating, or even thoughts of suicide. Shirley's symptoms, for instance, precisely meet these criteria.
Got it. And for Don, we're looking at a manic episode. How is that defined?
So this is characterized by 1 week or more of a persistently elevated, expansive, or sometimes irritable mood, along with high energy and intense goal-directed activity.
A full week.
Yes, a week or more for mania. And often this includes things like inflated self-esteem or grandiosity, a decreased need for sleep, like Dawn sleeping only 2 hours,
Right.
extreme talkativeness, racing thoughts, and engaging in impulsive or risky behaviors. Don's arrest after that shopping spree and his unwavering belief in his novel, perfect examples of these grandiose and risky elements. There's also a milder, shorter version called a hypomanic episode. It lasts just a few days, and it doesn't involve the same level of, say, functional impairment or psychotic features you might see in a full manic episode.
Okay, so less severe, shorter duration.
Exactly. And the ICD also outlines something called a mixed episode, where manic and depressive symptoms can rapidly alternate or even co-occur, sometimes within the same day. The DSM-5-TR now addresses this with a mixed features specifier that can be applied to either a manic or depressive episode.
Okay, so if these episodes, depressive, manic, hypomanic, mixed features are the building blocks, how do they combine to form the specific mood disorders we hear about?
Good question. They lead us to conditions like major depressive disorder, MDD. This involves one or more depressive episodes, but, and this is key, never a manic or hypomanic episode.
Just depression.
Just depression. And it's quite common, affecting maybe 2–6% of the global population. Then there's bipolar I disorder. The defining feature here is at least one manic episode.
The full manic episode, like Don's.
Exactly. While depressive or hypomanic episodes can also occur, they aren't required for this specific diagnosis. The mania is the key. Then bipolar II disorder. This involves experiencing both hypomanic episodes, the milder ones, and depressive episodes. But importantly, never a full manic episode.
So highs and lows, but the highs don't reach full mania.
Precisely. It's often considered less severe than bipolar I in terms of the peak mania, but the depressive episodes can be just as severe. The chapter also describes cyclothymic disorder, which is sort of a chronic pattern of fluctuating hypomanic and depressive symptoms that don't quite meet the full criteria for an episode, but they go on for at least 2 years.
Kind of like a lower-level long-term mood instability.
You could put it that way. And persistent depressive disorder, PDD, also known as dysthymia disorder, is basically a chronic, low-grade depression lasting 2 years or more.
Okay.
And beyond these core disorders, the chapter touches on other important categories, like premenstrual dysphoric disorder, PMDD, and disruptive mood dysregulation disorder, DMDD, mainly for children and adolescents, plus specifiers for things like postpartum depression and seasonal affective disorder, or SAD.
Right.
It's worth noting, too, the DSM and ICD, they do have slight differences in how they approach some of these nuances.
That's a lot of categories.
Mm-hmm.
Which I guess brings up a critical question for me. With all these diagnostic labels, how reliable and robust are these systems in truly capturing someone's experience? Are they, perfect?
That's where the critiques begin, and they're really important for anyone studying mental health to understand. These systems often face threshold problems.
Threshold problems.
Yeah, like how severe do symptoms need to be, and for how long, to cross the line from just normal human distress into a clinical disorder. It can be a fuzzy line.
I can see that.
We also see high comorbidity. That means individuals frequently meet criteria for multiple disorders at the same time, which makes us wonder.
If the categories are really distinct.
Exactly. Are we slicing the same underlying issues in different ways? And reliability in diagnosis can also be an issue. Particularly in field trials for MDD and DMDD and DSM-5, clinicians sometimes struggle to reach the same conclusion about the same patient.
One area that really sparked my interest in the chapter was the debate over the bereavement exclusion.
Ah, yes.
The DSM removed it, the ICD kept it. It forces us to ask, is normal, intense grief after losing a loved one the same as a clinical depressive episode?
It's a huge question.
And crucially, should a diagnosis depend on whether a clinician personally supports or opposes this exclusion? That feels like it has massive real-world implications for how we treat people who are mourning.
Absolutely. It highlights the philosophical differences embedded within these diagnostic manuals. It's not just science. There are values involved. The controversy around PMDD also brings this to the surface. Some critics see it as a potentially sexist category, pathologizing normal female experience.
Right.
While supporters argue it legitimizes truly extreme, impairing premenstrual symptoms, and can help reduce stigma for those who suffer severely. And beyond the DSM and ICD, we have alternative perspectives trying to address some of these issues. The PDM, Psychodynamic Diagnostic Manual, for instance, puts more emphasis on personality patterns and the person's subjective experience, moving beyond just a symptom checklist.
More holistic, maybe?
Perhaps. Then there's HiTOP, Hierarchical Taxonomy of Psychopathology, which takes a dimensional approach. It looks at depression and mania along internalizing and externalizing spectra, rather than forcing them into discrete boxes.
Interesting. So, like, on a continuum.
Exactly. And perhaps most controversially, there's the PTMF, Power Threat Meaning Framework. It really challenges the medical view altogether. It sees things like depressive symptoms not as illness, but as understandable, perhaps even adaptive responses to social adversity, trauma, and depression.
Wow, that's a radical departure.
It is. And if we step back for a moment, these alternative models, they really challenge us to think beyond simple labels and consider the underlying processes and the much broader contexts of mental distress.
So when we see such vigorous debates within the diagnostic landscape itself, I mean, it clearly shows us that our understanding is constantly evolving, doesn't it?
Absolutely. It's not static.
And speaking of evolution, it makes me wonder, how has our understanding of mood problems actually changed throughout history? It wasn't always DSM categories,
Yeah.
right?
Oh, definitely not. Historically, these conditions have been described in fascinatingly diverse ways. In ancient Greece, for example, madness was broadly categorized into frenzy, mania, and melancholy. But their idea of melancholy was much broader than our modern depression. It sometimes included things like hallucinations, and it was famously attributed to an imbalance of black bile, one of the four humors.
Right, the humoral theory. And then later.
Well, during the early Christian era, we find references to acedia. This described the low mood, apathy, and sort of spiritual boredom experienced by isolated monks.
Acedia, I think I read something about that term popping up again during the COVID lockdown.
Exactly. It saw a resurgence of discussion. Later, during the Renaissance, melancholia was often romanticized, sometimes seen as a companion to genius, even though the symptoms described were often quite severe.
The tortured artist trope.
Kind of. Then moving into the 19th and 20th centuries, a very popular diagnosis was neurasthenia.
Neurasthenia. What was that?
It described people whose nervous systems were supposedly exhausted by the stresses of modern life's industrialization, city living, that sort of thing.
So like burnout, almost.
Very much echoes of burnout or chronic fatigue syndrome today. This concept still subtly influences our modern understanding of loss of energy and depression. It's a clear historical thread connecting ancient melancholia to modern ideas.
Fascinating. This historical progression, then, eventually led to the pioneering work of Emil Kraepelin, right?
Yes, Kraepelin was crucial. In 1899, he famously placed depression and mania on a single manic-depressive illness continuum. His work greatly influenced the modern distinction we still use today: unipolar, meaning depression only, and bipolar, meaning alternating poles of mania and depression.
So Kraepelin really shaped the way we categorize these disorders now. Okay, let's shift gears now to the biological side where, brain chemistry and structure take center stage. What's striking here is just how much our understanding has advanced, even very recently.
Definitely. A cornerstone of biological psychiatry for decades has been the monoamine hypothesis.
Right, I've heard of that. The chemical imbalance theory.
Essentially, yes. This theory posits that depression is primarily due to a shortage of key neurotransmitters, brain chemicals like serotonin, norepinephrine, and dopamine. This hypothesis largely emerged after early antidepressants, like MAO inhibitors and tricyclics, were observed to alleviate depressive symptoms. These drugs work by basically increasing the availability of these monoamines.
Okay, and more recently we've seen the rise of SSRIs, right?
Yeah.
Like Prozac.
Exactly. Selective serotonin reuptake inhibitors, or SSRIs, like fluoxetine, Prozac, specifically block the reuptake of serotonin, making more of it available in the synapse, the gap between neurons. Similarly, SNRIs target both serotonin and norepinephrine, and we've seen a really rapid worldwide increase in the use of these antidepressants, particularly among women and older adults.
But their effectiveness, it's debated, isn't it?
It is widely debated. Psychologist Irving Kirsch, for example, published some controversial meta-analyses suggesting that antidepressants are not noticeably more effective than placebo pills, especially for mild to moderate depression.
Placebos. Really?
Well, particularly when factoring in active placebos pills that mimic the side effects of real drugs. This makes it harder for people in trials to guess if they got the real drug, potentially reducing the placebo effect difference.
But surely they work for some people. Critics like psychiatrist Peter Kramer argue strongly that Kirsch's studies were flawed and that antidepressants offer very real, significant benefits, especially in specific, more severe situations.
That's the counterargument. Yes, it's a very active debate.
Which makes me wonder, given the conflicting evidence and how readily these drugs are sometimes prescribed,
Yeah.
should antidepressants really be considered only as a last resort? What do you think? It's a tough question for our listeners to ponder.
It absolutely is. And beyond just the effectiveness debate, antidepressants come with their own challenges. Common side effects like headaches, insomnia, sexual dysfunction, those are real issues for many people. Also, when stopping SSRIs or SNRIs, many people experience what's called discontinuation syndrome. It's a cluster of often unpleasant symptoms, flu-like feelings, dizziness, electric shock sensations, anxiety.
So it's hard to come off them sometimes.
It can be, yes. And there's a debate about whether it should actually be called withdrawal syndrome, which carries different implications. And we can't forget the black box warning on antidepressants regarding a potential increased risk of suicidal thoughts and behaviors in adolescents and young adults. That warning remains highly contentious but is critically important.
Okay. And you mentioned the monoamine hypothesis itself isn't the whole story either.
Correct. It has shortcomings. There's that frustrating 2 to 4 week lag time before effects typically kick in, even though neurotransmitter levels change quickly.
Why the delay?
Good question. It suggests more complex downstream effects are involved. There's also some evidence that long-term SSRI use might actually lower serotonin levels over time in some brain areas. And the simple fact is, not all drugs that boost monoamines actually work as antidepressants.
So, if the monoamine hypothesis has its limits, where have researchers turned next? What else is happening in the brain?
Well, the glutamate hypothesis has gained a lot of traction recently. Glutamate is another key neurotransmitter, an excitatory one. This newer theory proposes that depression might be linked to problems in the glutamate system, perhaps too much activity in some areas.
Glutamate. Okay.
Yeah.
Has this led to new treatments?
Yes, quite significantly. It's opened doors to exciting, faster-acting treatments like ketamine. Ketamine, often used as an anesthetic, can have rapid antidepressant effects, sometimes within hours.
Hours. Wow. Compared to weeks for SSRIs.
Exactly. And its derivative, esketamine, delivered as a nasal spray called Spravato, is FDA approved for treatment-resistant depression. These can work within 24 hours. However, they aren't without issues. They're short-acting, require repeated administration, can have dissociative or hallucinatory side effects, potential for abuse, and need close medical supervision in a clinic setting.
So not a simple fix.
Definitely not. We're also seeing the development of new oral glutamate targeting pills, like a combination of dextromethorphan and bupropion, marketed as Auvelity.
Okay. And for bipolar disorder, are the drug approaches different?
Yes, the primary medications are mood stabilizers. The best known, and often considered the gold standard, is lithium. It's a naturally occurring metallic mineral salt.
Lithium. Heard of that one.
It can be very effective at managing both manic and depressive episodes and preventing relapse. But other medications, like certain anticonvulsants, like Depakote, which Dawn was prescribed, some benzodiazepines for short-term agitation, and newer antipsychotics, like Latuda, also prescribed for Dawn, are also frequently used as mood stabilizers.
So Dawn's medication combination makes sense in that context.
It does. It's common to use combinations to manage the complex symptoms of bipolar disorder. On a structural level, brain imaging studies also show differences. Specific regions like the hippocampus, involved in memory, the amygdala, emotions, and parts of the frontal lobe, mood regulation, decision-making, can show volume changes in individuals with depression and bipolar disorder.
Changes in the brain structure itself.
Yes, although the direction and consistency vary. And the HPA axis, the hypothalamic pituitary adrenal axis, which is our body's central stress response system and regulates cortisol release, is often found to be dysregulated in mood disorders. Too much stress hormone activity.
Right, the stress connection.
Yeah.
And for those cases where medications don't work well, are there other biological options?
Yes. For treatment-resistant cases, there are non-drug biological interventions. Electroconvulsive therapy, or ECT, is one.
ECT, that sounds intense.
It involves inducing a brief, controlled seizure using electrical current applied to the scalp. Despite its somewhat scary reputation, it's actually highly effective, often life-saving, for severe depression, mania, and postpartum depression, especially when other treatments fail.
But there are side effects.
Yes, the main ones are temporary memory loss and confusion around the time of treatment. Newer methods include transcranial magnetic stimulation, TMS, which uses magnetic pulses to stimulate specific brain areas non-invasively, and deep brain stimulation, DBS, which involves surgically implanted electrodes to stimulate specific brain circuits, is being explored for chronic severe depression, though it's still considered experimental for this use.
Okay, what about genetics? How much does that play a role?
Genetics definitely play a significant role. Family and twin studies consistently show that mood disorders are heritable, meaning they run in families. Particularly bipolar disorder seems to have a stronger genetic component than major depression.
But it's not just genes, right?
Absolutely not. It's never just about genes. Gene-environment interactions are crucial. Having a genetic predisposition doesn't guarantee you'll develop the disorder. Adverse life experiences, like childhood maltreatment or significant stress, often interact with those genetic vulnerabilities to increase risk.
That makes sense. And I found the evolutionary perspectives mentioned in the chapter really thought-provoking. The idea that depression could actually be adaptive.
Yes, that's a fascinating, though debated, area. Adaptationist models propose that maybe some forms of depression aren't just malfunctions. Maybe they serve a purpose.
Like what?
For instance, helping us avoid social risks after a defeat, or promoting rumination to solve complex problems, or even conserving energy during times when striving is futile or dangerous. If Shirley's depression after her demotion is seen as an adaptive way to maybe socially give in, conserve resources, and reflect on her next steps, well, that challenges the idea of immediately trying to eliminate the feeling with medication, doesn't it?
It really does.
In contrast, dysregulation models within evolutionary psychology simply view these same mechanisms as broken or malfunctioning, stuck in an on state when they shouldn't be. We also see biological links through things like circadian rhythm disruptions. Sleep-wake cycles are often profoundly disturbed, especially in bipolar disorder. This has led to therapies like light therapy and dark therapy to help reset those internal clocks.
Interesting.
And the inflammatory hypothesis is gaining ground too. It suggests a link between chronic, low-grade inflammation in the body part of the immune system response and the development of mood problems. Researchers are even exploring whether anti-inflammatory drugs might have antidepressant effects.
So connecting the immune system and mood.
Exactly. If we connect all this to the bigger picture, it becomes clear that while biology offers powerful tools and important insights, it also raises fundamental questions about what we truly understand about the cause versus correlation in these experiences.
So what does all of this biological research ultimately mean for someone like Shirley or Dawn? I mean, a major critique, as the chapter points out, is the persistent lack of definitive physical biomarkers for diagnosis, right?
That's a key point. We still diagnose based on observed behavior and reported symptoms, not a definitive blood test or brain scan, despite all this research.
And interestingly, feeling better after taking a drug doesn't necessarily prove a chemical imbalance caused the original problem.
Precisely. Just like taking an aspirin makes a headache better. But it doesn't mean the headache was caused by an aspirin deficiency. Or, as the chapter notes, smoking marijuana might make someone feel calm, but that doesn't mean they were pathologically anxious to begin with. Correlation isn't causation.
It's a complex picture, isn't it?
Very complex.
That's a powerful point. Let's pivot now and turn our attention to how our thoughts, feelings, and relationships also play a crucial role in understanding mood disorders, the psychological side.
Right. So, from a psychodynamic perspective, starting way back with Freud, depression was often viewed as tied to unresolved grief and loss. The idea was that anger towards a lost person or ideal gets repressed and turned inward, against the self.
Anger turned inward.
Yes. And mania, in this framework, was sometimes seen as the ego's sort of frantic defense mechanism against this intense internal anger or underlying depression. Building on this, attachment theory, rooted in the groundbreaking work of Harlow with monkeys and Bowlby with children, emphasizes how our early relationships with caregivers profoundly shape our emotional resilience and vulnerability later in life.
Our earliest bonds matter a lot.
Immensely. Insecure or disrupted attachment can lead to vulnerability to depression, sometimes seen in what's called anaclitic depression, a form of depression linked to early experiences of loss or a lack of consistent emotional support and care.
Okay, this understanding leads to modern psychodynamic therapies then.
Yes. Interpersonal therapy, IPT, for example, is a well-researched, short-term focused approach. It zeroes in on 4 key relational problem areas that often trigger or maintain depression: disputes in relationships, difficult life transitions, complicated grief, and interpersonal deficits or sensitivities.
Very practical and relationship-focused.
Exactly. Then there's intensive short-term dynamic psychotherapy, ISTDP. This approach is more focused on helping clients identify and experience hidden or blocked emotions, the anxiety associated with them, and the defense mechanisms they use to avoid those feelings. For Shirley, an ISTDP therapist might explore how she's unknowingly projecting her anger about her demotion onto her fiancé, Ralph, maybe blaming him instead of facing her feelings about work. The therapy would help her access and process those hidden conflicts.
Okay. Helping her connect with the underlying feelings.
Precisely. And specifically for mania, or bipolar disorder, there's interpersonal and social rhythm therapy, IPSRT. This adapts the principles of IPT to help clients regulate their daily routines, especially sleep habits, and manage their social interactions. It directly addresses those suspected circadian rhythm disruptions that are often a hallmark of bipolar disorder. Keeping life stable helps keep mood stable.
Stabilizing rhythms.
Yeah.
That makes sense. Okay, shifting now to cognitive behavioral therapy, or CBT. This seems like a really prominent approach.
It is hugely influential. Aaron Beck's cognitive theory attributes depression primarily to what he called the cognitive triad.
The triad, right. Negative views of it.
Negative beliefs about the self, negative beliefs about one's experiences or the world, and negative beliefs about the future. Shirley's conviction that she's unlikable, self, her job is awful experiences, and she'll be unhappy forever future, perfectly illustrates this gloomy negative outlet.
It tracks you.
It really does. And these core negative belief systems or schemas lead to cognitive distortions. These are habitual, irrational, or biased ways of thinking, like overgeneralization, one bad event means everything is bad, or personalization, taking blame for things that aren't your fault.
Okay. And what about Martin Seligman's work, learned helplessness?
Right, learned helplessness theory. This posits that depression can arise when an individual learns through experience that their behavior has no effect on their environment or outcomes. They learn to feel powerless. Shirley, for instance, not even bothering to look for a new job because she deeply believes her actions are pointless and won't make a difference that exemplifies learned helplessness.
Feeling trapped again.
Exactly. Hopelessness theory is an expansion of this, linking depression specifically to a certain style of attribution, the way people explain why events happen. When people consistently make explanations for negative events that are stable, meaning it's never going to change, global, it affects everything in my life, and internal, it's all my fault, they are much more vulnerable to developing hopelessness and depression.
That explanatory style is key. So how does CBT assess and treat this?
For assessment, CBT uses practical tools. The Beck Depression Inventory, BDI, is a widely used self-report questionnaire to measure symptom severity. The Daily Record of Dysfunctional Thoughts, DRDT, is a worksheet that helps clients identify triggering situations, their automatic negative thoughts, the emotions linked to them, and then work on developing more balanced, rational responses.
Very structured.
Yes. Therapeutically, behavioral activation is a core component. It sounds simple, but it's powerful. It encourages clients to schedule and engage in positive or meaningful activities, even if they don't feel like it initially, to counteract withdrawal and low mood. Problem-solving therapy, another CBT technique, helps clients break down overwhelming life problems into smaller, manageable steps and brainstorm solutions.
So for Shirley, CBT would involve maybe using the BDI, tracking her thoughts with the DRDT.
Exactly. And assigning activities she used to enjoy, like maybe going for a walk or calling a friend, even if she feels no motivation. Plus, directly challenging those irrational beliefs about her worth and her future using cognitive restructuring techniques.
And there's also mindfulness-based cognitive therapy.
Right, MBCT. This approach cleverly combines standard CBT techniques with mindfulness meditation practices. It teaches clients how to relate differently to their thoughts and feelings, observing them with acceptance and non-judgment, rather than getting caught up in them or automatically believing negative thoughts. It's particularly good for preventing relapse.
Okay. And for mania, can CBT help there too?
Yes, CDT is adapted for mania, often as an addition to medication. It helps patients monitor their mood and energy levels, recognize early warning signs of an episode, and reality test overly optimistic or grandiose beliefs. For Don, this could mean working with a therapist to challenge his belief about writing the greatest novel ever, maybe examining the evidence for and against that belief, and developing strategies to improve his medication adherence, which is often a major challenge when someone is manic or hypomanic.
Right. They might feel they don't need medication when they feel that good.
Exactly. That lack of insight can be part of the mania itself.
CBT is, as you said, hugely studied. What's the general verdict on its effectiveness for depression?
Well, CBT is arguably the most extensively researched therapeutic approach for depression. There's a large body of evidence supporting its effectiveness across various populations. It's often found to be comparable to, or in some studies, even more effective in the long run than antidepressants, particularly in preventing relapse. And of course, it doesn't have the physical side effects of medication.
That's significant. What about other psychological perspectives? Humanistic or emotion-focused?
Yes, humanistic perspectives, like Carl Rogers' person-centered therapy, view depression as stemming from psychological incongruence, a mismatch between one's real self and ideal self, often resulting from a lack of empathy and unconditional positive regard from others. The therapy aims to provide those conditions to foster greater self-acceptance and consistency.
Focusing on the person's potential for growth.
Right. And then there's emotion-focused therapy, EFT, developed by Leslie Greenberg and others. EFT really prioritizes emotion as the key agent of change. It views depression as often stemming from early, unsupportive, or invalidating childhood environments, leading to core maladaptive feelings like inadequacy, shame, fear, or hopelessness. For Shirley, an EFT therapist would help her access and explore those painful feelings of disappointment, shame, or anger related to her demotion and perhaps earlier experiences. The goal is to transform these maladaptive emotions by processing them and developing more adaptive emotional responses, often through the supportive, validating relationship with the therapist.
So really getting to the core feelings. It's clear that these therapies offer powerful ways to understand and shift an individual's internal landscape. But this brings up an important question for me. What's your take on the unique contribution of these psychological approaches, especially when compared to medication? What truly helps people make a lasting shift? Is it changing thoughts, processing emotions, the relationship?
That's really the million-dollar question in psychotherapy research, isn't it? While psychological therapies are clearly highly effective for depression, they're often used alongside medication for bipolar disorder, particularly to manage mania, given the severity and biological underpinnings. We know relapse can still occur even with therapy. And we also have to acknowledge spontaneous remission. Sometimes depression lifts on its own over time without formal treatment. The chapter also features an in-depth look at a really cutting-edge area: psychedelic-assisted therapy.
Ah, yes. Psilocybin, MDMA.
Exactly, combining hallucinogenic drugs like psilocybin from magic mushrooms or MDMA ecstasy with structured talk therapy sessions for conditions like severe depression and PTSD.
It sounds promising but controversial.
Highly. There's growing evidence, but also ongoing debates around efficacy, long-term safety, the potential for misuse, and the methodological challenge of separating the drug's direct effects from the intensive therapeutic support that accompanies it. It leads to a fascinating ethical and personal question. If given the opportunity and with proper medical screening and therapeutic support, would you be willing to undergo psychedelic-assisted therapy for a significant mental health challenge? Why or why not? It really pushes the boundaries of conventional treatment.
That's a truly thought-provoking question, bringing together the biological and psychological in a novel way. Okay, finally, let's zoom out to the broader world. Because our social environment, our culture, our relationships, these profoundly shape our mental well-being, often in ways we don't immediately recognize.
Absolutely. Sociocultural perspectives powerfully emphasize how factors like materialism, social comparison fueled by social media, experiences of discrimination or social oppression, and especially socioeconomic inequality are deeply linked to depression rates.
Inequality itself.
Yes. Research consistently shows that things like lower earnings, poverty, unemployment, and living in disadvantaged neighborhoods correlate with significantly higher rates of depression and anxiety. This perspective argues powerfully that effective mental health solutions must include social economic policies that promote fairness and opportunity, not just individual therapy or medication.
So tackling the root social causes.
In part, yes. We also see clear gender differences in diagnosis and antidepressant use. Women are diagnosed with depression roughly twice as often as men and take more antidepressants.
Why is that?
Well, that's the big question. Is it that women are truly more prone to depression due to biological or psychosocial factors? Or is there a gender bias in diagnosis? Perhaps men are socialized to express distress differently, maybe as anger, irritability, or substance use, so their depression gets missed or misdiagnosed.
That makes sense.
The silencing the self, STS theory, offers one feminist perspective. It suggests that women's depression can be a product of internalizing cultural demands to suppress their own thoughts, feelings, and needs to maintain relationships or fit into a historically male-centered world. And in some contexts, antidepressants might even function subtly as a form of social control, helping women cope with untenable situations rather than changing them.
Wow, that's a critical lens.
It is, and the chapter also rightly highlights crucial service user perspectives. Listening to people with lived experience underscores the intense, debilitating, and often deeply stigmatizing reality of depression. Users frequently express complex feelings about medication, often valuing it during an acute crisis, but being ambivalent about long-term use, worrying about side effects or dependency, sometimes feeling it numbs them. Their voices are essential.
Absolutely. And from a systems perspective, thinking about families and relationships.
Right. From a systems perspective, depression and mania are strongly associated with relationship problems. For example, marital distress and divorce significantly increase the risk for mood disorders and even suicide. And mood problems themselves put immense strain on relationships. It's often a vicious cycle.
Cause and effect get tangled.
Exactly. Imagine Shirley's depression. It inevitably impacts her fiancé, Ralph. He might feel burdened, taking on more responsibilities, frustrated by her withdrawal, maybe even guilty or helpless. This can lead to significant relationship strain, conflict, and sometimes even Ralph might start feeling depressed himself. It's a systemic effect.
It affects the whole family unit.
Precisely. This concept is crucial for understanding expressed emotion, or EE. This refers to patterns of communication within a family, specifically high levels of criticism, hostility, or emotional over-involvement directed towards the person with the mental health problem. High E from family members is a strong predictor of relapse, particularly in bipolar disorder and schizophrenia.
So how the family reacts really matters.
Yeah, immensely. This insight has led to the development of effective family therapies. Family-focused therapy, FFT, for bipolar disorder, for example, emphasizes psychoeducation, helping the family understand the illness, improving communication skills, and enhancing problem-solving abilities within the family unit. Attachment-based family therapy is used effectively for depressed and suicidal adolescents, working on repairing relational ruptures. These approaches highlight that mood problems don't just emerge from within individuals in isolation. They often arise from and are maintained by problematic or unsupportive relationship systems. Stepping back for a moment, these sociocultural and systems perspectives powerfully remind us that mental distress isn't solely an individual internal experience. It's deeply embedded in our social fabric, our culture, and our closest relationships.
It's clear that while sociocultural factors don't explain everything, obviously, many people in difficult circumstances don't develop mood issues. And some, from very advantaged backgrounds, do they provide such a vital counterweight to purely individualistic or biological viewpoints. They push us to consider social reform and systemic change alongside individual treatment. Wow, what a journey through the intricate world of depression and mania. We've really covered a lot of ground. We've seen how these mood states are defined, the fascinating ways diagnostic systems attempt to categorize them.
And the debates around those systems?
Exactly. And the rich history of their understanding, plus the vast array of biological, psychological, and sociocultural perspectives.
Indeed. We've explored everything from, brain chemistry and genetics all the way to cognitive distortions, attachment styles, and the profound impact of societal inequalities. It's abundantly clear there's no single simple answer to understanding or treating these complex conditions, is there?
Not at all.
Each perspective offers valuable insights, and often the most effective approaches seem to be integrative, combining elements from multiple viewpoints tailored to the individual. Which brings up, I think, an important closing question. How can we best integrate these diverse perspectives, the biological, the psychological, the social, to create a truly holistic, effective, and compassionate approach to mental health care?
That is a powerful question for all of us studying mental health, and frankly, for anyone engaged with mental well-being in our society. So as you continue your own journey in understanding this field, maybe consider this parting thought. How might acknowledging the potential adaptive function of some forms of sadness, as those evolutionary models suggest, actually change our societal approach? Are we sometimes too quick to treat every down mood, perhaps missing an important signal or process? What if some sadness has a purpose we're inadvertently medicating away?
Food for thought.
Definitely. Thank you so much for joining us on this deep dive today. Keep questioning, keep learning, and keep connecting these complex ideas to the real world around you. We really appreciate you tuning in, and we hope this deep dive has given you a real shortcut to being well-informed on depression and mania.